We're now going to welcome Matt Ritter to the podium. Matt is the Chief of Academic Surgery at the Uniformed Services University of the Health Sciences and also Chief of Laparoscopic Surgery at the U.S. Naval Medical Center. He's going to talk to us some more about establishing training objectives, proficiency, or time-based measures. Matt?
Thanks, John. My role at USUS, in addition to what's listed there, is over the past 5 years I've actually helped roll out the FLS program to all 13 surgical GME programs in the Department of Defense. So specifically on the topic of incorporating it into a residency program, I've probably seen almost any conceptual way you might think of to incorporate it. So if anybody wants to find me after, feel free to run me down and ask me questions. What I'm going to talk about specifically on this talk is different ways of establishing these training objectives as you incorporate what you saw earlier as the well-validated metric of FLS. How do you get your residents to train on these so that they can pass these tests and reach these milestones? That's my only disclosure, not relevant to this presentation. So what I'll talk about is a little bit of the fundamentals of skills training that Jerry touched on, options for creating skills training objectives, really kind of writing a training prescription for your residents, and then give a couple examples, and Jerry mentioned one that I'll highlight a little bit more, but examples of how we've put these into actual practice and used them in a practical way. So again, any skills training curriculum kind of has to be broken down into these key phases. But before they start training, watching them be trained, and then going into this deliberate practice or this skills refinement phase. And if you're going to try to do this third phase in a self-paced environment, which the realities of most of our programs is such that we can't really have faculty mentors on the order of 8 to 10 hours in a skills lab. So it's very important to get them to this this skills refinement phase of this deliberate practice phase where they can go on their own. And then eventually, like Jerry mentioned, the trainee demonstrates the acquired skill in some manner, either retesting on the platform like FLS or demonstrating that acquired skill in the operating room. So the pre-training phase, very important to have the trainee understand the task. And this is very important when you're training with abstract tasks like you find in FLS and FES, because they're not intuitive. They're not like residency in the operating room, but they are well deconstructed recreations of the core skill set. But it's important that they conceptualize what they are supposed to be doing with the task. They maybe watch an expert perform it. They can talk through what they're supposed to do. And probably equally as important as knowing what to do is knowing what not to do, or what is unacceptable. And one of the examples of that in FLS is not being allowed to balance the little triangle on one of the posts in peg transfer. I mean, there's a bunch of little intricacies to each task that it's important that you don't turn them loose to practice without them clearly knowing not to practice a skill like that. The mentored practice phase, again, very important. You're watching them, like Jerry alluded to, giving feedback, making corrections, and monitoring them until you're confident that they understand the skills enough that they can get into that skills refinement phase on their own. And then the deliberate practice or the refinement phase, the trainee basically can practice what they've learned in the prior steps. As we've seen in multiple studies, the performance will certainly improve, the skill will automate, but the common question you get when you talk about the actual practicality of administering a program like this in your residency is how long does it take? And the answer to that, of course, it's kind of like asking how long's a string, right? And it depends on the string. So for each person, training to this level of performance is probably going to take a different amount of time. We'll talk about how we can control some of those variables here. So when we're deciding how we're going to practically implement this for a training program, you basically have 3 different variables you can control. You can have your trainees train for a specific amount of time. You can tell them they have to do each one of these tasks for a certain number of repetitions. Or because you have a nicely validated tool with metrics like FLS or FES, you can actually use the skill, the performance skill, as a controllable variable. And all of these are going to be confounded by baseline ability. So we'll go through some hypothetical examples of what this looks like, this, controlling these different variables and what the outcome may be. So again, this is hypothetical, but if you have the gifted trainee in red and the less gifted trainee in blue, if you have a program where you tell your trainees you've got X amount of time to train, what can happen is what's illustrated here. The less gifted trainees in any given amount of time are going to be able to complete fewer repetitions. Their skill's going to improve, but you have the potential of getting this big divide kind of between the haves and the have-nots. Your more gifted trainee is going to be able to do more repetitions, is probably going to be further up on that learning curve just based on natural abilities than your less gifted trainee. And you potentially widen that gap between the haves and have-nots. And then you may not reach, if that bar to the right there is your goal of what skill level you want your trainees to perform at, you may or may not be reaching that goal. Your variability is along that skill axis, and that's not ideal. You can see a similar pattern with repetition limited training, right? So the same below average and gifted trainee, it's going to take your below average trainee more time to be able to do whatever number of repetitions you've kind of arbitrarily decided that they need to do. Their performance will improve, but again, your naturally more gifted trainees are going to progress at a faster pace than those who don't come to the table with the same dexterity. And again, your variability is going to be exactly how much skill is acquired by any one of those trainees during the program. So if you have a simulation platform like FLS or FES that has built-in metrics you can measure, you can incorporate this concept that's talked about a lot of proficiency-based training or criterion-based training. There's a bunch of different names that basically mean the same thing. And the concept is this, that any expert at a skill has a certain amount of that skill that they walk around with every day. Any type of validated platform with metrics has the ability to quantify a certain percentage of that skill. Okay? How much of that skill gets quantified is going to depend on how well the individual tasks of the training program are constructed, etc. But some percentage of that skill is going to be quantifiable. If you set that quantifiable amount as your target for your trainees, what that allows you to do is basically get as much bang for your buck as you can out of whatever simulation platform you're using. So your learners can basically train until their measured skill level is the same as the skill level measured on those experts. And one of the additional beauties to this is as the fidelity of the simulators improves and you can measure more and more of that expert's true skill, your proficiency level changes, but the concept is still the same. If you're having the trainees train to the level of the experts on the platform, then you're not wasting time and you're not getting variability in the product that comes out of that training program. Okay. So then what you would see for a skill limited or a proficiency-based curriculum would be something like this, where you're controlling for skill, so your two variables are how long do they take and how many repetitions do they do. So what you find here is that your gifted trainees get it done quicker with fewer repetitions. Your less gifted trainees spend more time and more repetitions, but they all basically reach the same goal. So this should, in theory, give you a better utilization of your simulation resource. Everybody has a limited amount of this type of resource, so you don't want people who don't need it to be taking up your training time, and you want that to be available for those who do. So in theory, this is the appeal of a proficiency-based, skill-limited training curriculum. So that's all good in theory, but does this kind of thing work? So the first question we answer is, does this proficiency-based training work? And we have a couple examples of how we've applied it and gotten good results. So the first is a study that Danny Scott and I kind of pioneered back a few years ago when we were first trying to develop a proficiency-based curriculum for FLS. And we set it up with all the key components that Jerry outlined, this proficiency-based, deliberate practice. It was distributed over 1 to 2 hour training sessions. And our goal was to measure its effectiveness initially in terms of being able to train folks to pass the FLS examination. So we generated this table here, and this is basically the proficiency levels that were generated for each of the 5 FLS tasks. And you can see on here, keeping with the initial concept of FLS, each one of these has not only a time, but also a maximum amount of error that's allowed. So you can't do it quick and sloppy, you have to do it quick and well, and then certain anchors in terms of number of consecutive trials done, and then for the key aspects, some additional, for suturing and for peg transfer, some additional reinforcement of those tasks. So we piloted this on MS 1s and 2s, not PGYs, but medical students, so complete novices. They went through the outline that you see here. They had some pre-training where we discussed all those cognitive aspects of the skill, make sure they understood what they were doing, made sure they were executing the tasks properly. They did a pre-test, they had some mentored practice, and then they went into this proficiency-based curriculum and then came back for an FLS post-test. So what we found, is what you would expect of a well-validated assessment tool. Pre-test, none of the first and second year medical students passed, and by about half, they scored about half of what the passing score would be. They went through the curriculum, took these complete novices somewhere between 8 and 10 hours there to do it. You can see a rough estimate of the number of trials, and you can see some of that variability presenting itself in there in terms of the haves and the have-nots. Some people taking 100 trials on the peg transfer versus 40, et cetera, that kind of thing. But everybody was able to go through the curriculum and at least achieve the proficiency levels on each of the tasks, at least the 2 consecutive times. And when they came back for the post-test, you can see basically everyone passed, and everyone passed with a healthy margin. So it was widely applicable and led to good skills retention and good skills improvement. When you plot this out graphically, you really see this concept of decreased variability kind of play out here. So in the pre-test, you see the wide scatter of folks based on the amount of abilities that they bring to the table. And then as you come to the post-test, you see your nice cluster up here of much less variability in performance. The other thing that you see is some of these lines, these aren't parallel lines, so some of the folks that started out down here, ended up here. So it allows folks who maybe don't have the best natural abilities to acquire that skill set, and it does tend to build some confidence. We also looked at it in terms of retainability. So this is a graph of this FLS test. Pre-test is in blue, and then several post-tests. This is immediate post-training test, then at 6 months, then at 12 months, and you see very good retainability. And again, these are in medical students, so they're not doing any laparoscopy. And then we also did a number of trials to see how quickly they would spontaneously recover, even in this delay, to the level of performance immediately post-training. And we're able to show that basically within 3 trials, the blue is immediate post-training, and then the yellow and pink are the 6 and 12 months. And you can see by trial 3, they're basically performing at the level they were immediately post-training. So training to this level of proficiency led to at least a durability of this skill set up to 12 months. So that's all great in terms of passing the FLS test, but as Jerry alluded to, you want to show that you're actually training skills that are helpful in the operating room. This is the study that he referenced briefly, obviously from his group in McGill. They basically applied a very similar curriculum to a group of mostly PGY 1s and 2s who were very well matched, not terribly experienced, and found a couple things. One, in terms of pre and post FLS score, they very much replicated the data that Danny and I showed, where basically almost no one passed pre-test. The training group all passed basically post-test, and there was quite a bit of variability in the non-training group for the FLS score. But the interesting thing that he referenced was this improvement in terms of the goals score in the training group, and you can see the post-training score here, the goals score versus the non-training group, and this chart's down here for reference. So you can see a 17 is somewhere in their PGY 3-4 range versus the PGY 1-2 range, which is down around this 13. So that's the equivalence of that 2 years of residency training that he had referenced. So the answer, I think, based on those data to question one is that, yeah, it does work. It works in terms of basically studying for the test, but it also works in terms of improving real skill as it relates to operative performance. So the other question then is it better than the time-based or the repetition-based training? And to answer that, and there's another study that used at least a part of FLS, and this was actually just presented last week at the ASE from a group here from San Antonio, and a very similar kind of format to what we had done before. Medical students, they used the intracorporeal suturing task, and they randomized to groups of training for 60 minutes, training for 5 trials, or they set a proficiency level of performing the intracorporeal suturing in 3 minutes with 1 millimeter of suture placement error, and they had to do that 2 consecutive times. And the results that they presented are very interesting from a number of aspects. So you see from left to right, time-based training, repetition-based training, and then proficiency-based training. So just like we saw in our hypothetical models, you see, basically the time-based training, much less in terms of overall score, and in this scoring system, higher is better. So you see a lower score in the time-based training, as well as this huge variability represented by the standard deviation, the error bars here. The repetition-based training did better for whatever reason, but still has considerable variability, but clearly on the performance score in terms of both overall performance and variability of performance, the proficiency-based group was best. We looked at it in terms of training time. Again, you see obviously the time-based was limited to 60 minutes, so you wouldn't expect much variability there. Took a little over an hour for the repetition-based group, and quite a bit more time obviously for the proficiency-based group, but this is where you see your variability, and I would argue this is what you want to see variability in. This is showing that your natural performers are hitting probably right around 60-65 minutes or so in terms of their total training time, while your less natural performers are maybe more out to 2 hours. But the key is applying your simulation resources to those who need it most so that they can achieve the skill set that they need to achieve. The number of trials, again, mirrors very much the training time. I thought it was interesting that the repetition-based group did fewer trials but took longer. I mean, they were limited to 5, but it took them a little over an hour, whereas in the time-based group, they did about 6 trials. I'm not sure, I'm not sure exactly how that equates. Maybe they knew they only had to do 5, so they goofed off more. I don't know. But again, a lot of variability here in the mean number of trials in the proficiency group, reflecting those who are natural versus non-natural performers. And this is just a graphic representation of the efficiency in minutes per trial, and again, maximized for the proficiency-based group. So based on these, I think we can say in terms of utilization of expensive simulation-based resources and producing the desired outcome, that proficiency-based training is better for these type of applied abstract simulation training models. So in conclusion, I think that we can say that skills training curricula should obviously first establish correct performance of the training task to make sure that if you go into one of these reinforced deliberate practice scenarios, you're not training someone to do something incorrectly, because the worst scenario we can get into is trying to unlearn a habit that has been reinforced through proficiency-based training. And then refinement of learned skills certainly can be accomplished using any of these defined training objectives, but I think there's reasonably good evidence to show that in a simulation environment, when you can easily and rapidly measure the actual skill and task performance, that training to levels of proficiency is effective and superior to those other training objectives. Thanks.